Hello, good afternoon. And see, that's what we were discussing last time, that we'll be starting a completely new series, and we are starting with upper limb. So every Saturday and Sunday, for these 2 hours, right, we'll be completing one full topic, complete topic. So today, as we'll be starting with pectoral region, right, we'll be covering lots of grounds. So starting with those areas, as every time we discuss, that this would be our system. We'll not be taking anything for granted, right? So it would be like, first we'll create a base. Now how shall we create the base in case of upper limb? By feeling our own bones. So when we say yes, I can feel this bone, that means it will stay in your mind, and then rest of the structures, they'll be oriented exactly from that spot. So thus no guessworks, everything would be completely crystal clear. Okay, so I think it's time to start. Let's start with our first session, right, on pectoral region. Tomorrow it's very important because the base of today will be taken tomorrow. Tomorrow we'll be discussing one of the very fine topic, and that would be the brachial plexus. But when we'll be discussing brachial plexus, at that time we'll not be talking about things which we have already discussed today. So over there it might happen like straight away we'll go to the point that these are the things, that is how the brachial plexus is formed, its relation, its muscles, right, everything will be discussed straight away. Today we'll be understanding the complete foundation. So that's how every time, right, we'll keep on learning one step, one by one, and then next day will be based on that step. That way we'll complete the entire limb. During our course of entire discussion, there would be lots and lots and lots of figure. In fact, today you'll see that there will be hardly any scene without any image, right? Because anatomy is something, it itself tells, no, that is, you cut and see, you cut and observe, right? So that's what will follow. All right, so here we start. Now see, when we talk about upper limb, there has to be a purpose, right? There has to be a purpose why we are having upper limb. The purpose of upper limb is that it keeps that arm away from the chest. Yeah, it keeps our arm away from the chest wall. Now, this is needed when we really want to improve our efficiency. Mechanical efficiency is much more increased, right? So that's the reason there has to be a bone supporting it. Yes, there would be a bone. When we say pectoral region, it is nothing much, but it is the front of chest. But we will be talking about even the shoulder, etc. Okay. So here is our skull, right? Rest of the bones. But right now we are interested in this one bone, and that is clavicle. Why we straight away talked about clavicle? Because we say that the function, this function of this clavicle is to keep the arm away from the chest, right? So that's why this is what is acting as a bone, and this bone is a transverse bone, right? Normally, you'll see that all the long bones, they are situated vertically, right? But this particular bone, it has got several characteristics. See, right? This is a transverse, or the transverse, or we can say this is horizontally situated. This is the horizontal bone. See, horizontal. Another important thing is, when I say something, you palpate, right? You feel that entire bone. You will be able to feel that entire bone. So this is palpable, right? There would be several characteristics of the clavicle written one after another, but we'll start feeling every point once we really understand it. So horizontal is fine. Palpable, yes. Can you palpate? Yes. Then it is said you can palpable because it is just underneath the skin. So we call it subcutaneous. So that is also a very valid point. That's why it should be palpable. One more thing which is written, that this is an S-shaped bone. Now, it doesn't look like S-shape. So there has to be another angle from where we have to really see that is this bone S-shaped, right? Let's see. This is where we are watching it from the top, right? We are watching it from the top. So now it makes sense, right? It makes sense. It looks like S-shape. It looks like this S-shape. Now when the shape is like this, then it has got one pressure point or the area where it really shifts the weight. And you are lifting a heavy weight. This weight would be transmitted to the body via this clavicle. So when this weight is getting transmitted, it is at one point where there would be severe stress. So in case if it is much more, this point can break. That's why we are understanding this. And we'll see few cases also, we'll see few x-rays also, right? So that we know that yes, what we are understanding is proper. Okay, so this is the S-shaped bone, right? That's the S. Do focus on this, that this curve, where these two curves meet. Now, whenever the two curves meet, medically, we have to define that point. So now we know it very well that what is medial and what is what is medial and what is lateral, correct? So here, if we are dividing this bone, so can we say that this is the junction of lateral 1/3 and medial 2/3? Can we say that, right? So just it is like this. This is our bone and that's the 2/3 and this is the 1/3. This is the junction of lateral 1/3 and medial 2/3. Right now, this much knowing is sufficient. We proceed, right? So here it is. This is like will watch everything from different perspectives. Watch for this joint. That's humerus, right? And see, these are, right? You must be knowing these names, but don't worry, right now they'll come. But these are the prominences. In between that prominence, there is a groove. This is what we were discussing, right? But here is the scapula. That's the scapula. This one. Can we feel the scapula? Yes, we can. Just you put your hand on the back and on both the sides, right? You feel the scapula. That's your scapula. But on scapula, just on the tip, on the top, just put your hand over here and you will feel a bony prominence, right? That bony prominence is acromion process. Acromion process, right? See, it takes turn, right? But it is this portion. It is this. This is what you are feeling. And this acromion process is okay. Oh, got clavicle broken. Yeah, it's a commonest fracture. It's a commonest fracture, especially when someone falls on the outstretched hand. It's a very common fracture. And when we'll be taking that discussion, let's say in case if someone falls like this, right from the scaphoid to then all the way, then this is Colles fracture. Which fractures they actually break, right? Which fractures actually occur, which bones actually break. All those things you'll automatically understand once you'll see that where exactly the weight is getting transmitted, right? That's why these points are very interesting. So it takes away that pressure when we are learning the surgery or the orthopedics. Okay, so here is the acromion process, and obviously this is clavicle, right? That we have already talked about. So I would like to give name to this joint. So let's use both these names. It is the acromioclavicular joint, right? Acromioclavicular joint. Acromioclavicular clavicular joint. So this is the normal convention that it makes life bit easy, correct? Okay, let's see in reality. This is a real body. See, in reality, things are not as romantic as it really looks like into those figures. This is the real joint. It really looks like this, bit eroded, right? They will see some of the muscles and actual muscles. That is, when you open the body, they look like it, right? So this is now easy for us to identify. We can now identify clavicle. We can now identify acromion process. This much is sufficient for this point of time, and this is the scapula. Yes, that also we know, though we know the ribs, etc., but right now we'll not talk about it. We'll take everything step by step. Okay, here it is now. As we know, acromioclavicular process, where it goes, right? This is acromioclavicular joint, but on the medial aspect, here it is going towards what's called as the sternum, right? So here is sternum. That's sternum, and this shield-like structure, this is manubrium, right? This is, which is like this, right? This is manubrium. I'm interested in this junction. This junction. The junction over here, right? This particular junction. Just a minute. Just a minute. Give me a minute. Okay. Now it should be better. Yeah, this is better, right? Okay. So coming back to this junction, this is what is called as the manubriosternal junction. Again, the same style, right? Manubrio, that is between manubrium and the sternum. Sternal junction. There is another name of it, that is angle of Louis. This is another name. Do remember this name. As we'll be learning, as we'll be going into thorax, when we'll be discussing thorax, you'll find that so many structures, they are either emerging or they are ending at this point. One of the best example is this. That is in case of arch of aorta. In case of aorta, it is like this ascending aorta, right? Then there was an arch of aorta, and then there was descending aorta, correct? If you draw a line like this, so it is this level which is the angle of Louis. That's the level. Manubriosternal angle. That's the angle. Right. So we can say that ascending aorta ends at the level of angle of Louis. Arch of aorta starts at the level of angle Louis and it ends at the angle of Louis. And the descending aorta starts at this. In simple words, that's the thing, that this is the level. Right. So many other things also they do occur at this point. But this is just for an example. Otherwise, say it would come in extensive detail in thorax. The point which is important over here is, see the ribs. Start counting the ribs. This is a small rib. This is first rib, right? That's a second rib. This rib, and I just remove this, right? This rib, right? This is a bony structure, but then there would be a cartilage. So it will go like this, and this space would be filled up. So that's the second costal cartilage, right? So all these grooves, right? What you see, all those ribs, they will be going and they'll be attaching. But over here, manubriosternal junction, so we just say that it is at this junction, so many structures start and, right, one thing, it is also called as angle of Louis, and don't forget this, it is the second costal cartilage joins here. So see, we are learning now systematically, the whole image would start building up, right? Because then once it is created, then we'll start inserting muscles one by one, right? And then between those muscles, we'll start putting arteries, and then we'll put nerves. And then we'll be studying those nerves in detail. So we'll be covering complete ground till we learn those nerves, because tomorrow straight away we'll be learning about those nerves, and at that point we'll say that obviously it is this pectoralis major is over here, minor is here, right? All those muscles, you'll be learning all those muscles. Okay, moving further. Now, as we said that is our angle of Louis, but here is very interesting little bone, this X. So X is nothing but X is xiphoid process, right? Xiphoid process. And this xiphoid process, this area, right? This area, it is also called as the epigastric. And its importance, this epigastric fossa, right? Epigastric fossa or epigastric area, it has got lots of importance in the surgery, right? And the pain in epigastric fossa, etc. But we again are interested in learning one thing, and that is which rib will be landing over there. So let's count it. Let's see. Right, here it is. So first, that's second. Let's make it red color. So this is 1, that's 2, that's 3, that's 4, this is 5, that's 6, and this is 7. Okay. Well, we are finding it bit difficult that where exactly is landing. So why not to introduce costal cartilages now? Now it makes sense, right? Otherwise it was bit of guesswork. See the difference between both of them. Over here we have just put the bones, okay, and to these bones, otherwise it is the seventh costal cartilage, but it never looks so convincing that how they really take turn. Now it is, see, this is easy. Okay, so let's put numbers again. 1, 2, 3, 4, this is 5, 6, and that's 7. Here is the seventh costal cartilage which goes into this direction and it gets attached at this xiphoid. Right? This is the last costal cartilage. Otherwise 8, then it goes into this, right? It is merging into the seventh only. And that's how the entire thoracic cavity is formed. See, all these are costal cartilage. So from now onwards, we'll write the costal cartilages as CC, right? Because it will keep on coming again and again. So we'll try to minimize our, say, keywords. Done? Okay. Moving further. Now in this case, we shall dive bit deep. I'll zoom this thing. I'll zoom still further. This makes sense. This is good. Okay. Our intention is that this clavicle is so important. Yeah, floating ribs. Right? These are the last ribs, those 11th and 12th, right? That we are coming to that. So from here to here, this is clavicle, and the middle point of clavicle is called as what? Midclavicular line, right? Midclavicular line. So if I draw a straight line, which we are dropping from that point, so it would be passing through. Let's see. So this is 1, that's 2, this is 3, 4, 5, that's 6, that's 7, this is 8, and then this is 9. Okay, that line I drew, that was slightly shifted. It is not very parallel. Okay, let's draw. It would actually be passing through, right? Through like this. Okay. Right? It would go via tip of, this is tip of ninth costal cartilage. I mean ninth rib, right? The junction of ninth rib and the costal cartilage. So that ninth rib tip, that is into mid-clavicular line. So this is what is called as the mid-clavicular line. Do we need to remember these things? Yes, very much. Because every point will be used at a later stage for many of the functions. And why are we taking this? We are not telling anything from the acromion process, because say it is easy to palpate the clavicle, right? And when you palpate the clavicle, then you can figure out that, okay, this is the center. And then from that center, you can really make it out how to go. So that's why they are also called as the landmarks, right? Exactly the same way when we tell anyone that, okay, there is a tall building, there would be a big tree, right? You take a right turn, left turn. That's so basically we do have a habit of using landmarks. So these are nothing, but these are the bony landmarks. These are the bony landmarks which will help us all the way. Okay. Next is the next is that's junction, right? The lateral 1/3 and the medial 2/3. This particular junction, just underneath, right? If you see, if you feel, you'll find a depression. You'll find that in your body, right? When you'll touch, you'll find that yes, there is something like a depression, fossa, right? That's what is called as the fossa. This fossa is just underneath the clavicle, so we'll call it infraclavicular fossa. Infraclavicular fossa. Right? That's what we say. It is at the junction of lateral 1/3 and medial 2/3. Even if you'll see by yourself, you'll be able to figure it out. Yes, it is over there, right? Easy to find out. This fossa is important. Yes, it is important. We'll see its importance. But how to figure out? By this method. Right? Okay. Moving further. Now see, we are introducing muscle. We are introducing the biggest muscle first. The muscle which is easiest to identify. And as we are learning pectoral region, pectoral means it is front of chest. It is front of chest. And this pectoral region, the muscle which is most important, biggest muscle, so that's why we'll call it a major muscle. When we are telling major muscle, it means there has to be a smaller muscle exactly quite similar at a quite similar location. Yes, and we call it pectoralis major, right? A muscle, big muscle, which is associated with the front of chest, and that's the pectoralis major. This is a big muscle. Now, for this muscle, right, when we are talking about this particular muscle, this muscle is forming a boundary, is forming a wall. Which wall are we talking about? Say we said that this is our clavicle, and just underneath the clavicle there is a fossa. And if we say that this particular fossa is important, so we should know that, okay, how will it really form? So easiest wall we picked up, that is in the front, because the moment we remove the skin, it is this big muscle, pectoralis major. So this pectoralis major will be forming a wall, right? So that's what just you keep in mind, and as we'll proceed, we'll see that how that fossa is really formed. This is infraclavicular fossa, right? That's what we are focusing on. But if you watch very carefully, it is in the chest, so we'll call it pectoral fossa, right? Because it is in the chest. But at the same time, on one of its sides, there is another big muscle, right? This big muscle. This muscle which is giving curve to your shoulders, right? Which is giving curve to your shoulders. That is the deltoid, right? That's the deltoid. So we have introduced second member, and that is deltoid. So that's why this thing is like deltopectoral. That is something which is associated with the shoulder. So this is like a depression. This is like a depression which is where at the junction of lateral 1/3 and the medial 2/3. Fair enough. We have changed the angle a slightly. Slightly we have changed the angle because we want to see one. This is the muscle which we are watching for the last time, and then we'll remove it and we'll be going deep. This is the muscle which is called as platysma. It is called as platysma. This muscle is subcutaneous, right? It is the subcutaneous muscle. So when you forcibly depress your neck, right, you'll be able to feel that entire muscle, this platysma. What is its importance, etc.? More or less, you can see that it is for expression. Otherwise, it is just a covering, quite a thin muscle. And that's, you know now it is the pectoralis major. We'll start writing now pectoralis major gradually slowly and gradually in its short forms. So right now we are writing it pectoralis MJ, right? Soon we'll be writing it like pectoralis major, like this. No confusion. Right? So at the end, when you'll start labeling, it is perfectly fine if you just write it like pectoralis major, because it is for anyone it is difficult, but for you it is easy. You know that this is pectoralis major, right? No need to write all those lengthy words. It is only in the initial stage. Okay, moving next. That's in reality, right? Beauty is just skin deep. This is the muscle. This is the muscle, right? That's the pectoralis major. This one. Big muscle. See, right? So we'll say this is pectoralis major. Now, watch. Important thing is it has got so many fibers, right? It is arising from here, all the way to sternum, right? And it has got so many. It is like a fan shaped. And speciality is one point which we have to keep in mind, that these muscles, these fibers, they can contract individually. So it is very much possible that only this top portion would contract. So then the action of muscle would change. And when only this bottom, this part would contract, so then our action would change. This muscle is bypassing the scapula. Right? There are only two muscles which are bypassing the scapula. It means they are connected to the body and then they are connected to the arm. So this means they are very powerful muscles, such big muscles. One we talked about, pectoralis major, right? Second will come soon. But it is connected to that humerus, right? It is connected to humerus. In other words, it is connected to arm. This is the muscle which is between arm and the chest, right? That's how it is connected. So this is how it really looks like. That's platysma, and you know it very well that is platysma, right? Very prominent. Okay. Now we have removed the platysma, so it is not there. Rest of the muscle, right? All those small muscles over here, right? They are part of head and neck. So we'll not touch them. We'll touch few of the muscles as they will arrive and as they'll be needed. But currently our focus is purely on this one. That's clavicle. We know it now very well. That's deltoid. No problems about it. This is pectoralis major. True. Watch for that. There are few muscles which we are watching over here, right? It means this is a major muscle. So there is one muscle which is just underneath. So what name would you like to give it? Obviously it would be pectoralis minor. So we are introducing one more candidate in this, pectoralis minor, right? To see this thing, we'll see that where this thing is really attached. We know this part, and we said that this is a clavicular joint. Clavicular joint. Sometimes we confuse ourselves. How it happens? That there is one more process. It is called as the coracoid process. Coracoid process. Again, right now there won't be any confusion. There won't be any problem because we know that yes, this is acromio, this is clavicular, everything. Yeah, sure. This fossa would come. So this is acromion, this is coracoid process. But then after some time, there starts some confusion. So again, in order to reduce the load on your brain, remember acromio means top. Acromio is top, right? A is first. A is on the top. So over here, what you feel over here, right? When you touch your own shoulder and the bone which you feel at the top is acromio. Now there won't be any confusion because there is another piece which is coracoid process. Coracoid is crow-like. Huh? It is crow-like. Right? We'll see it at another angle, but that's what is called as the coracoid process, or crow-like, like a beak of the crow, right? Crow-like. In reality, right? Here it is, right? Just another angle. Now we have to see it from the back. We are watching it from the back side. So that's spine, right? That's the spine which we are watching. And this is scapula. Now scapula is in full view. We just want to see and focus on this area, because this is the area which can actually harass you during exam. So that's why let's finish it first. This is what is called as the spine of scapula, and you can feel the spine of scapula very easily. Parallelly, as I'm telling, just keep on feeling. So take your hand back and you can feel that entire spine of scapula. So from where will you start? You will start from that point. What is that point? That is acromion process. This acromion process is exactly on the top. Just go back, right? When you go in front, you'll find that that's the clavicle. Immediately, this is the clavicle, right? That's the clavicle. And then that's the acromion process. Take a turn, go back and trace all the way. And that's how your hand is moving, right? Your hand is moving all the way like this, right? You were here, this was the top. In front, you were going, that was clavicle. And now when you are going back, this is spine of scapula. No confusion. So it means this is, can you really sense that? See, it is forming something like this, right? A space, right? A space, right? A complete curve, right? Okay. And that's spine of scapula. We'll always add one extra word because we can feel it. It means it is palpable. It is palpable. You can palpate it, right? Acromion was the top. Clavicle was subcutaneous. That's why palpable. Spine of scapula is palpable because it is also subcutaneous. So can you palpate this area above and below? This, this area and this area? No, not. Why? One thing is it would be attached with muscles. And second, they are not prominent, right? Anything which is prominent only, that can be felt. So when we touch over here, it is prominent. That's why we are feeling it, right? So we'll not mark this thing. Good. Let's move on to the next page. Here it is, right? This is another, say, posterior view, and see how this spine looks like. This is how the spine looks like. There are all the parts of the spine, and then there are several muscles attached, right? Everything would come. And in fact, the names are so simple. This, if we know this is as spine, right? You know what is superior, what is inferior, right? So a muscle, which is a very important muscle, which is just above the spine, so we'll call it supra. And muscle which is just below the spine, we'll call it infra. Now above and below what? Spine. So let's say supraspinatus and infraspinatus, right? So they will come, but we just leaked our paper, right? So these are the next questions which are coming up. Okay, let's move further. Here it is. The bones which are already known to us, but we are watching it in focus of this spine. So here is the spine. That's the spine of scapula. Now when that's the spine of scapula, two very smart muscles, they are getting displayed over here, right? This we know. This is deltoid, right? He showed his presence by giving curve to the shoulder, right? So that's the deltoid. And when we say it gives curve to the shoulder, it looks like bit of non-medico, right? If you are medico, you should use some smart words, and those words are like it gives. Now see how impressive it looks. Otherwise, meaning is same. It gives round contour to the shoulder, right? Contour to the shoulder. Contour is nothing but it is the shape, right? It gives that shape. And over here, this is like a kite, right? This muscle. And so those who are into gymming, right? They really work very hard. Actually, they work very hard. That's the muscle which carries tremendous importance in bodybuilding. So when those bodybuilders, right, they really take the position. So it is this muscle, it is this trapezius, right? It is kite shaped. So this kite shaped muscle, which is called as the trapezius, it is seen very clearly. So trapezius, we took it because it is connected with the spine. So now we know that there is something over here and there is something over here. So then where are those supraspinatus and infraspinatus? Well, they are relatively small muscles and they are just underneath it, right? So the moment we'll remove them, we'll see those muscles. In fact, some muscles are seen also. Here it is. See how they really look like. That's the spine, right? And all those muscles are supraspinatus. It is just our deltoid and the trapezius, right? That's the deltoid. That's the deltoid. In fact, deltoid has got three parts. We'll see all those parts step by step, one by one. Right? Now coming back to this, that's pectoralis major. This is deltoid. And they all are going towards the arm, or in other words, humerus, right now we'll just write arm to make it simple. But can you figure out it is forming something over here? This is what is called as the axilla, or simple language, armpit. So when you actually keep your hand like this, the depression which you get, right, that is what is axilla. This axilla, it is a very important space, and this space is like a pyramidal space, right? It is like a pyramidal space. So when we say pyramidal, right, how do you say that pyramidal? Pyramid is something like this, right, like this. So that's what is called as the pyramid, right? So pyramid has always one apex. Then it has got the base. So that's the apex. That's the base. That's the base. And then it has got walls on all the sides, right? Pretty easy. Now these walls over here, they are like anterior and posterior, medial and lateral walls, right? What exactly are we trying to say? What we are trying to say is, think of that this pectoralis major is in front, right? It is in front. So there would be one muscle which will be on the back side. Then, so we are through with, say, this is the muscle which we are talking about. That's what is called as the latissimus dorsi, right? I'm just writing in short. We are coming to that muscle. This muscle, huh? Don't think about this. No. We are talking about this muscle, latissimus dorsi. Latissimus dorsi is another muscle. Why? Because it gives V shape to your body, right? Actually, when you work out, the V shape of your body is because of this latissimus dorsi. Also, will lovingly call this muscle from this point onwards as lats, right? It looks stylish, and we do remember also. This is very important muscle. Now, say sidetracking a bit, there is one what is called as the kettlebell, right? All those who are very much interested in say in your fitness, and in case if you really wish to create a strong upper body, right? What was written was very right, that while running a long distance race, right, my clavicle was broken, right? Either it could be because of fall, right? But when we said that when you are running long distances, you are not running long distances with your feet, you are running with your upper body, because your upper body should be absolutely stable. Then and then you have got the endurance. Kettlebell is like a Russian exercise. It's like a big ball, and then it has got the handle. But that is slightly off center. So when you are holding it and then when you are doing the exercise, right? So that exercise will be giving you tremendous advantage. And these are the exercises which are called as the kettlebell exercises. One of the most powerful exercise, basically invented and prepared by Russian commandos. Okay, coming back to this, it is this exercise which takes care of all these two major muscles, pectoralis major and latissimus dorsi. Yeah, because of fall, I got it. Okay, see the real in real life how the things like see these muscles, they are having so much, but right, this is so much of specific clearly defined margins. Now you can really see that okay, this is how every structure is literally seen. So coming back to this, so we said that it was the axilla, right? It was the axilla which we were talking about. So here is the pectoralis major, and as we try to go slightly deep, here is another muscle. So take it like this, that this one, that's the pectoralis major, it's the anterior wall, and here is taking another color, this is the posterior wall, right? We'll see this thing from another angle, but from this angle, at least you can appreciate that there is anterior wall, there is a posterior wall, and in between structures, they are all these, right? They are the in-between structures. That's how the axilla is getting formed. So over here, it is the anterior fold, right? Anterior fold. That's that's the thing, what I was talking about. This is the tendon of latissimus dorsi. Latissimus dorsi. So that's latissimus dorsi, and this obviously will be forming the posterior fold. Easy. And what is in between is nothing but axilla. That's the axilla. This was the anterior fold. Anterior. Let's dive deep in. So we are into now axilla. This is the structure within. Right? But after that, there is nothing. So this is the medial most structure. True, right? So we say anterior, posterior, and then that structure, this one, which is like a thoracic cage, right? In fact, it is thoracic cage. There were ribs, and on those ribs, these are all those muscles. So these are what's called as the serratus anterior. Again, serratus anterior, because it has got striations, it has got 8 slips, right? 1, 2, 3, 4, 5, 6, 7, 8. That's how it will go. We'll see all of them in detail because it makes a very specific sense that why they are like this. But when they are going like this, 1, 2, 3, 4, 5, 7, 8, they are forming what's called as the medial wall, right? So we are now into medial wall. So medial side, That's how it is formed. And thus we have formed all the three sides, and thus we'll see that what it is at that point. Here it is. Let's look a bit more further. See, if you can appreciate, that was the deltoid, right? That's the deltoid. This muscle, what we are watching, is another big muscle which you always try to flex, right? Yes, this is biceps. This is biceps. All your dumbbell exercises, right? We focus on this muscle. The name is biceps. Ceps means head, right? So this is biceps. It means it has got two heads. Two heads. When there are two heads, so we need to define it, right? So one of the head is long and another head is relatively short. So that's why we said short head and long head. So here what we are dealing is, this is the short head of biceps. Where is the long head? That's a short head. This one is the long head. This one, long head. But his head doesn't seem that long because it is underneath. And where is it going? It is going into that groove. You remember that? Right? There was a groove we talked about, and that groove, name of that groove was bicipital groove. Bicipital groove. Deliberately we gave that name, that it is like a depression, it is like a ridge, and through that, right, it passed, and this is the bicipital groove. So that long head will actually pass through that bicipital groove and will go all the way into the capsule. So we'll see that, but this is the reason that everything is so beautifully interconnected. This is deeper structure, right? So, but now we know that it is long because it is going all the way. Let's see that. Yes, we would like to see that. Okay. So if we cut, right, now don't confuse this, right? Watch very carefully. I'm again taking it back, and then we are moving on to next one. Taking it back, moving on to the next one. What's the difference? It is not the same muscle, right? It is not the same muscle. This particular muscle, that is simply short head of biceps, what if we really cut that muscle and we remove it? When we do that, there is, can you really appreciate a small muscle over here? I'm marking it like this, right? This muscle, this one. Oh, okay. The muscle which I'm marking with this red line, right? Only a thin one is seen. Now I'll remove it. So you should be able to see it. Yes, we are talking about this particular muscle, this one. Okay. So if we just remove short head of biceps, we just put a cut and we remove it. Now what you are watching, this one, is brachialis. Brachialis means this is arm. And this coraco, you find this word similar, right? Familiar to something which we already talked about. You're right, coracoid process. So this is going from all the way from coracoid process to the arm. This is, friends, this is coracobrachialis. So we learned one more thing, that this coracobrachialis is just underneath the short head of biceps. True? So we have covered this deltoid part. Deltoid, still we have not seen it in more depth, and all these structures are seen when we removed pectoralis major. Pectoralis major was removed, and then we are watching that structure. Two structures which we watched very closely, and they were like biceps, two head, right, and long head and short head. Short head is what we what is right now in focus. We cut the short head, and underneath the short head we saw this coracobrachialis. Long head we have not touched yet, but we just know that long head is long because it is going through that bicipital groove, right? Remember bicipital groove. Okay. So again, when I say that this is back to our pectoralis major, if it is said that what are the structures passing underneath, under pectoralis major, right? This would be a very common question, structure passing or structures which are present, right? I should, instead of passing, let's use the word structures present, right? That makes more sense. Structures present under pectoralis major. So first thing which we are watching is that it is covering this, what's called as the serratus anterior, because it was forming the medial wall, serratus anterior, right? It is forming the medial wall of axilla. Okay, axilla is armpit. Pectoralis major is forming the anterior fold, right? Latissimus dorsi was forming the posterior fold. Now, in serratus anterior, there are 8 slips, 8 serrations, 8 strips. Out of that, it is 1, 2, 3, 4. Only first four, they will be actually forming. They will be just underneath this pectoralis major. So first 4, upper 4 ribs, right? Upper, because see, these are nothing but those are the ribs. So upper 4 ribs, and on that connected is serratus anterior, is what is seen over here. Okay, let's move further. Yeah, here it is one chupa hua muscle, right? Very smart, very nice muscle, but bit hidden. It's quite small. The name is not at all complicated because we know that it is what? Clavicle. Anything which is above, it is supra. Anything which is below, it is infra, or it is sub. So we'll call this thing as subclavius. Subclavius. This is a muscle which is just underneath this clavicle. Now see, because of its connectivity, it is like a small muscle, a very small muscle. What can it really do? Nothing much. It will say that when the movements would be there, this clavicle is going to move immensely. So its function would be, it steadies the clavicle. It steadies the clavicle. That would be first function. And tomorrow when we'll see that yes, all those nerves, etc., they are passing, right? Those nerves, etc., when they will be passing, it is this small muscle which is creating a very nice space, giving support to those important arteries, veins, and the nerves. And those nerves are what? They are the brachial plexus. That would be our tomorrow's topic, brachial plexus. So tomorrow we'll not be talking about subclavius. As we'll be discussing straight away, we'll see it this way, that here is the subclavius, this is how it is supporting, and then you'll see that they are going, and subclavius is taking part in that support, right? So all good. Moving further, there was pectoralis major, so here is its chota bhai, right? He is pectoralis minor, and actually he looks like the chota bhai, you know. So this is pectoralis minor, and pectoralis minor is going where? Yes, it is going on that coracoid process. Coracoid process. So good, so good. Right? See how important the coracoid process is. So if I ask you a question that which are the structures attached to coracoid process, immediately your answer would go something like this, that pectoralis minor, sorry, it's a fan-shaped muscle and it would be inserted at the coracoid process, right? Because it is getting inserted at a smaller point, right? It is inserted at a smaller point, however its base is bigger. So thus this is the muscle which will actually give power, right? Because it has got big fan and then landing on a small spot. At the same time, there is one more muscle which will be connected to the arm, that is in the form of what's called as the coracobrachialis. And this coracobrachialis, where is it? It is just underneath the short head of biceps. How precise are you? Everything clear, right? So that's it. This is the coracobrachialis, right? And coracobrachialis, you know where it is. See, just one very important point you must remember. I am not insulting any of the books. I am not insulting any of the faculty. But what I'm telling you is that every time you revise, right, you revise it in one specific order only. So that way, slowly and gradually, you will be so powerful because there would be a specific sequence. You can definitely learn it like, okay, let's start with straight away the subclavius, right? We'll talk about the clavicle at the end. And then we jump on to pectoralis major. And then we say, acha, these are the serratus anterior. And then we go deep and we say that was the serratus posterior. Yeah, we can do that, right? Obviously, all the muscles would be connected. They are connected and we'll learn step by step. But if you follow one particular order, you'll be able to remember, and actually it will start creating the picture. Anatomy is nothing but creating that picture. So when you revise, right, I'll show you. I will keep one session on that how to revise. But right now not. Right now, you'll be going by this entire lengthy method. Because if you start going shortcuts right from the beginning, you'll miss something. But then, trust me, one day is what is needed. Just one day. And you'll be able to revise the entire upper limb in its entirety. Everything. Similarly, if I say that it is the just 1 week which is needed to revise your entire anatomy, yes, very much possible. If you follow that pattern, slowly and gradually, it will be still faster. And one day you will close your eyes and then you'll start speaking. Okay, this is how whole thing goes. What type of questions can be asked from anatomy? Don't worry about the questions. Just learn, just understand, right? It is like your understanding is tested. Because if I'll disclose that these type of questions, immediately you'll be biased that yes, I need to remember this. Rest of the structures which they are not asked much. No, we don't want your brain to be biased. You have got immense time, enough time for the exam. Don't worry about it. And initially, at least for next 10, 20, 30 lectures, at least for 1, 2, 3 months, no, we'll not be going from the perspective of exam. We'll be going from the perspective of your understanding. Okay. Then when it will be the exam time, I'll tell you that focus on these areas. But right now, don't worry about the exam, right? Because you are heading for that final exam when you will be actually dealing with the patients, when you'll be doing the surgeries, when you'll be one of the finest and the top doctors. So that would be the real exam, right? Otherwise, all those exams, so they are just in between, they are minor, right? When you will be handling your own hospital, or when you will be head of the department of some reputed institutes, so at that point, you will be playing your final exams. They will be your real exams. Otherwise, बाकी की बीच वाली exams, so they are all minor, right? So don't worry. Okay. So you know now this coracoid process well. Okay. Next. Here is our smart serratus anterior. See how nicely it's showing. It's all the levels. 1, 2, 3, 4, 5, 6, 7, and then that 8 one is bit hidden, right? It's bit deep. So this is serratus anterior, right? No doubt about it that this is serratus. Serratus, remember, is from serrations. Whenever you will see the serrations, that means those stripes. And as it is anteriorly situated, so we'll be calling it serratus anterior. And remember, this S, it's like 8. So this is 8 striations. And we are suddenly looking at this muscle. This is what it is. biceps, right? A big bulge. And this bulge is seen, we removed some muscle, right? We removed one muscle which was giving contour, rounded contour to our shoulder, and that was, you're right, that is deltoid, right? So we removed that deltoid. How can I draw faster during class to keep notes? Okay, that's right. That's right. It's difficult to write notes in anatomy because of figures. Very good point. Very good point. Okay, just remind me, right? Just remind me for this point before we close today's session. Right now, just understand it. But yes, this is a very good, very important point, and it's good that you have asked it at this stage. And we'll actually learn that method, right? Even if we'll go bit overboard, even if it is another 5-7 minutes extra, but we'll learn this thing. Just kindly remind me of this when we finish the topic. Okay. Right now I'm not taking because we'll deviate. Else the whatever the picture which is getting created in your brain, that will disperse. We don't want that. But at the end, definitely we'll talk about it. Please remind me. Yeah, thank you. Okay, coming back to the serratus anterior, and it has got 8 strips, and this is the biceps, and this biceps, this is like a short head, but now it is this long head which is giving its presence. And as we said that, yeah, it is going through, let's change the color, and it is going through that groove. See it, very nicely spatially designed groove, right? On both the side there are prominence, and in between it is this majestically, this groove is going all the way, and it is going into that joint capsule. Yes, that's why it is so interesting, and this is the reason its length is increasing. Otherwise, from the bulk wise, you'll see that there is not much of the difference. It is a long and short head of biceps, right? 2. Okay, next one. Seen much better and very easy to identify. So these are, right, all these are ribs, right? These are ribs, right? This is it is not ribs, it is rib. Okay, that's rib, right? This is also rib. In between the ribs, it's what is called as the intercostal muscles. These are intercostal muscles. So between those ribs, I'm thinking of starting the respiratory system in physiology, right? You will be updated about it, but this time respiratory system will be taken its full, complete, right? All the topics, and parallelly, the moment it would be complete, back to back, we'll also be taking the pathology. In fact, many of the topics, so they will be taken parallel with the physiology only, but some of the topics which would be left out, they'll be taken as special pathology. And yes, then the pharmac also. Now, don't feel that well, I am in first year, right? Will right now will not be touching the immunity part, will surely be taking, right, after certain topics. It will definitely come, promise, right? So over here, say, once this entire portion is complete, you'll gain tremendous confidence. And it is at that point when all those intercostal muscles, that what exactly is like that bucket handle movement, what are various respiratory movements, how it increases the various lengths and the diameters of the chest, what really happens when there is inspiration, expiration, all those parts, they will be covered in the physiology part, right? So this will give you tremendous cutting edge. Now, if you feel that, yes, I am into first year, and isn't it like a huge task? Not at all. Means, do you really feel so that as soon as it is labeled that, okay, now you are into second year of MBBS, and immediately there will be development of few gyri and sulci in your brain, suddenly your intelligence level and your ability to remember the things will go skyrocket. Any day you have to learn pathology, any day you have to learn pharmacology, so then why to worry, right? In fact, it would be much easier. You have learned, say, physiology, you learned that normal, and back to back you are learning abnormal, so it will start making the sense that this is how it goes, right? And then you will coordinate with onto your intercostal muscles, so they will be coming into this part. Good. Okay, so here are the intercostal muscles which we talked about. Let's move further. Now this is easy, right? You know this part. So this is biceps, and I need not even say more about it as you know it so well, right? These are the, that's the short head. So I'll just write it like this. That's the long head. So that's the long head, and that's the bicipital groove. Do remember this bicipital groove, right? Bicipital groove. Some structures you should never ever forget. And this one was between the coracoid process and the arm, right? So that is coracobrachialis. Few things we are repeating again and again so that you don't have to revise. You don't have to revise. We are finishing your revision over here only, because 45 minutes to 1 hour, if the things are not getting repeated, suddenly we start forgetting something. So that's why there will be spaced. This is what is called as the spaced repetition or the spaced revision. We'll keep on doing such things time to time. So when we'll be discussing brachial plexus, some of these structures, right, they will come like a flash, fatafat. Within a minute or two, we'll be talking about it. Okay, we have cut one structure. This structure, right? Can you see one particular structure has been cut? Can you name which structure we have cut? Right? Can you see this is a cut, right? Something has been cut. What has been cut? You can type. You can type. Right? Write down which structure has been cut. Can you see? Should I highlight it? This is the structure, right, which I am drawing in form of yellow color. Which structure is this? Okay. I'll not say anything, but you do attempt. You know, Kuzma, you wrote some answer, but trust me, your confidence level would be very high. I'm not telling right or wrong, but your confidence level would be very high because it requires some guts too. Okay. See, sure. Yeah, it is a groove. It is a groove, but in that groove there is something. So if you have deltoid muscle, no, here it is. Now the correct answer has come. See, I told you one thing. Remember, bicipital groove, right? Now listen carefully. Listen carefully. In bicipital groove, what goes? It was the long head of biceps which was going. Long head of biceps, when it is going through the groove, it is traveling and then it is landing into the capsule of that joint, right? So it has to be long head. Short head was going where? Where was the short head going? Short head was the going just on this coracoid process. है ना? So see this, right? Here it is. Just before a minute, right? We saw this thing. And then how can you write a short head, right? Short head was here. This is the short head color. This is the short head, right? See now how we say that, yes, this is the long head, right? That long head is because it is because of this path. That's how it goes. This is why it is long. Okay. Now see the orientation. No mistake. Okay, so this is our long head. But it is very good that you gave the answer first. It is very good. When you give the answer first, it becomes like that in some suspense story, right? You answered it that this is he is the culprit, and then you figure out, oh, no, 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 the murderer, the assassin was someone else. Then you feel, "Arey yaar, how can I make this mistake?" But then in your life, you will never make this mistake again. Here you are free to make as many mistakes as possible, because this is like your home ground. Make mistakes, do right answer, because when I see that 1 2 3 4 6 7 8 9 10 12 13 answers, right? We are having more than 50 people. So why there were only 13? What really happened to those rest of the 35 plus people? Why? When I'm asking, give the answer bindas, boldly write it down. Don't worry about that someone has written something else, right? I don't want, because say I won't be even knowing that in from which country, from which place are you. But when you answer correctly or incorrectly, right, that is what gives me energy. I feel that yes, you are connected, you know. Otherwise, I can't see you. But when you type something, when you write something, that's where I feel that connection. And when multiple answers appear, that's what I feel that yes, yes, yes. Now they are understanding it. Okay. There is no problem when you said that yes, it was shorthead. No problems. It happens. Right. So, okay. Making a star. This muscle is what? Fatafat, huh? Now rapidly I'll ask one, two, three. Two, three questions I'll ask. This star which I have drawn is on which muscle, right? These stars I'm talking about. I'm watching, right? Which muscle are we talking about? These stars are. Hmm. You are always okay. Good, good, good. All right. How about this muscle? This particular muscle which I am drawing. These are which muscles? Hmm. These are. So that was right. That was serratus anterior, which has got 8 strips. And then these yellow, they are intercostal muscles. Good. Right. Good. Very good. Now next is, as we know now the musculature quite well, we are introducing one artery. This is the artery, a huge one, a very important one. It is axillary artery. And what is the location of this axillary artery? Yeah, name itself is telling axilla, right? So this is the artery which will be into axilla. So if artery is there, so then there has to be the vein. Yes, it is the called as axillary vein, and same course, same location, right? So now we know that in the axillary, in the axilla, we have got axillary artery and the axillary vein. Very good. And what would be the boundaries? Well, the anteriorly there would be pectoralis major, right? Posteriorly it was latissimus dorsi, and medially it was serratus anterior, and then axillary artery and the axillary vein, they are going into the axilla. Axilla, which is a which is called as the armpit. What is its shape? Its shape is pyramidal. So when we say its shape is pyramidal, right? So it was having four boundaries or four surfaces, right? So one was the base, and then it was having four surfaces. Those four surfaces were what? Those four surfaces were anterior and posterior. So anterior surface is by pectoralis major, correct? And okay, let me write here. So it was having anterior and the posterior wall. Anterior was by pectoralis major, posterior by latissimus dorsi, and the medial by serratus anterior, right? Good. And that's our brachial plexus. Here it is. That's the brachial plexus. Those nerves, right? That entire group of nerves collectively. Plexus means group. Plexus means group. And brachial means it is the arm. So a group of nerves which will be taking care of the arm, that is what is called as the brachial plexus. And this brachial plexus is along axillary artery. And this brachial plexus is going into axilla. So in axilla, now we have got brachial plexus, axillary artery, and the axillary vein. And with its boundaries medially on serratus anterior, anteriorly it is pectoralis major, and posteriorly it is latissimus dorsi. Lateral boundary, it is deficient. It is just covered by the skin and those superficial fascia. So that's how that space is created, right? That's how the space is created. Okay, we'll be adding few more structures. Okay. Before proceeding, let's see this super powerful muscle, pectoralis major, individually. This is a muscle which is starting all the way. See how big the span it is. This is where it is, that's the clavicle, right? So it is the, and this is the medial part, right? So it is the medial 2/3 of the clavicle it is attached. Then it is going all the way to this manubrium. Then it is going all the way to this sternum. And then it is going towards those costal cartilage, right? Here was 7th. So here it would be roughly around 6th. So 6th costal cartilage, right? That's where it origins. So this is what is called as the origin of pectoralis major. So that's the pectoralis major and its origin. And it is going all the way to the humerus, right? So when this muscle contracts, it will be affecting the arm. This is the reason that in gym, you'll see that all those powerful, right? They really contract. So because when you are doing that fly, so that pec deck, all those fly, so they are like contracting the major pectoralis muscle. Seeing it from different angle. That's where we would like to see the insertion. So this was the origin from where it starts, and from here, this is the insertion. This insertion is on humerus. Now, this insertion is this was what it was, tubercle, right? So greater tubercle, lesser tubercle. Yes. Watch this. Watch only this part. This is what that bicipital groove, and that bicipital groove we can also call it intertubercular sulcus. Sulcus means depression, right? Sulcus is depression. So here, if this is a gap, so then there is one which is called as the lateral lip, and second is the medial lip. Lateral is because it is outside, so obviously here it is outside, right? So this point is laterally situated. That's the intertubercular sulcus. So that lip is lateral lip. So we say that it is lateral lip of intertubercular sulcus. That's where this pectoralis major inserts. So that was the origin and that's the insertion. Okay. Now if this is the situation, here is the greater, here is the greater tubercle, just watching it closely, and this is the lesser tubercle. So I would like to draw it like this, right? Instead of writing, we say this is greater tubercle and this is the lesser tubercle, and in between we have got this bicipital groove, and this bicipital groove will also be called as intertubercular sulcus as it is between two tubercles, and in that we have got the lateral lip, and it is the lateral lip of intertubercular sulcus or the bicipital groove where the pectoralis major is inserted, right? So do remember lateral groove, right? Lateral or lateral lip, not groove, it has to be lip. Okay, lateral lip of intertubercular sulcus. All right, now see this muscle, it has got two layers, one is in front, one is in back. So we can say that anterior and the posterior, or in other words we can make it like superficial and the deep. Easy, so that becomes much easier to remember. Superficial and deep. This superficial portion is from clavicle. Now it is forming the picture, right? It is forming the picture. Superficial layer, this one, right? This one, this is clavicle. So all those fibers which are coming from here, right? They are superficial fibers. And then rest of the fibers, they are coming from where? Those deep fibers, they are obviously coming from rest of the area. So that is from manubrium sterni. So manubrium sterni. So they are the deep fibers. Now, is it creating the picture that from clavicle, the fibers are superficial and those from the manubrium sterni, they are going into deep. So that's how the layer is formed. It means those fibers which are from clavicle, they can contract individually. These fibers, they can contract individually. Clavicle, it is above. So when those top fibers would contract, it will pull the hand up, and when those lower fibers would contract, it will take the hand down. You know, right? We'll see in more detail, but just understand that clavicle, they are superficial fibers, and the deep, they are the deeper, that is from the sternum, manubrium sterni, they are the deeper fibers. Okay. Looking from the posterior aspect, as we said that there is posterior lamina, right? This is the posterior layer, that's the posterior layer, complete posterior layer. This is thin. So let me divide it like easy. So here is the pectoralis major. In pectoralis major, we have got anterior and posterior layers, also called as lamina. In anterior, we have got superficial and deep fibers, right? And these superficial fibers, they were from clavicle. And those deep fibers, deep means they are just underneath this superficial one, that is the fibers which are coming from clavicle. So these deep, they are coming from, say, manubrium sterni, right? They are the deeper fibers. These are the posterior fibers. These are the posterior fibers, that is what is called as the posterior lamina, right? This is also anterior lamina. Then these posterior fibers, they are from 2 to 6 costal cartilage, right? So these are all the costal cartilage. From there, these fibers, they emerge, the second layer. But this is quite thin, right? This is quite thin. The major bulk is handled by this only, right? There is another component which deliberately I am avoiding at this point of time. That is, it is also like external oblique aponeurosis. Bindas, right now, just don't worry about it. Just remember that it is some tough structure, right, from which few of the fibers they will be emerging, because this is part of when we'll be discussing anterior abdominal wall. But at that point its importance is going to come. Right now, not much, right? So just, even if you don't remember it, it is completely fine, right? What really matters is as you start building up the whole concept, this thing will come automatically. So completely okay. All right. So here it is about pectoralis major. Now this pectoralis major muscle, it is supplied by, we have to talk about its nerve supply, right? Who will be supplying it? This is a big muscle, right? Suddenly out of thin air I said that who is supplying it, because its name is easy, right? Its name is easy because its name is pectoral, right? So obviously it will be supplied by pectoral nerve, right? This pectoral nerve. Friends, I am creating a small link for tomorrow's topic, right? For tomorrow's topic. It's because that these nerves, they will be linked tomorrow. So here is the pectoral nerve, and it is the medial and lateral pectoral nerve. So they are supplying this pectoralis major, right? So just remember, as the names are similar, pectoral nerve, pectoralis major, so medial and lateral pectoral nerve will be supplying it. What function it will do? The function of this powerful muscle, obviously in gym, when you were doing like this, right, when you were taking your hand near to your body, right, it is what is called as the adduction, right? You are adding something to the body, it is called as the adduction. So that's the powerful function of it. It is moving into the transverse plane, so this is what is called as the transverse adduction. It is the transverse adduction from 90-degree all the way to this, because if you take your hand back, so then there are other muscles involved, right? It is only, so that's why when you do exercise in gym, your actually position is like this, and then your hands move, because you really don't cross 90-degree, because you want to focus only on those pectoralis major muscles, right? So that's why it goes like that. So these muscles are 0 to 90 degrees of your transverse adduction. Add, right? They are coming near. So that is adduction. Okay. Another one. As we said that these muscles, right, they work in groups. So these are the clavicular fibers and these are the sternal fibers. True. When these muscles, they are connected to that groove, so it can also lead to medial rotation. So that's your arm, and if this is right, this is the medial rotation. When that's the arm, it moves inside, right? It is what is called as the medial rotation of arm. Why it is giving medial rotation? Because it is attached on the lateral lip, right? It is connected on the lateral lip of intertubercular sulcus. So obviously it is connected out. So when it will contract, it will take the hand in, right? It will rotate in. Right? Because it is connected on the lateral side. So that's the second function. First we learned adduction. Second is the medial rotation. When you see it from the posterior aspect, right? Now see, that's the latissimus dorsi, right? Or we say lats, right? This is our latissimus dorsi. Introducing one more muscle. This is deltoid, that also is well known to you, and this is the posterior view, right? Here it is, see, can we see? This is the pectoralis major. This yellow one is the pectoralis major. So pectoralis major, latissimus dorsi, all good. But then This muscle draws our attention. Here it is, here, this muscle, right? It is a separate muscle. This is a different muscle. Here it is. This muscle is teres major. And that's why onto that intertubercular sulcus, a very easy way to remember that where these muscles are connected, right? It is like lady between two majors. So on the lateral aspect, what was that? It was pectoralis major, right? Pectoralis major. On the medial lip, right? On the medial lip, there is another major. So that is teres major. It is teres major. And in between, that is our latissimus dorsi, lats, right? So that's how you remember, so that you don't forget at all. Now you have come across one more new muscle, teres major. If there is teres major, there has to be teres minor. Very true. There has to be teres minor. So keep in mind, right? There would be somewhere hidden the teres minor, but surely the size of the teres minor would be smaller, right? The teres major is bigger. Okay. Things are properly getting oriented. Okay. See over here. This is when only clavicular head. Now see, we are just talking about when only the clavicular head contracts only. Rest of the muscle is lying as it is. Only the clavicular head, right? When clavicular head contracts, right? Clavicular head or clavicular fibers, right? When they contract, it leads to, yes, right? See these muscles contracted, only these. So when these top muscles they contract, right? This, so they'll take the hand up, right? So that is what is called as the shoulder flexion. Right? When the shoulder, see that surface is coming near, right? This surface is coming near. So that is shoulder flexion, and it is occurring at glenohumeral joint. Now that's a new word. Humeral, it makes sense, right? Humerus, that's our bone, right? That is good. What is this gleno? Gleno means it came from the word glenoid cavity, right? A cavity which is shallow, right? Where is it? There are no other bones. There is only one bone which can have this cavity, and that is our scapula, and that's what is called as the glenoid cavity, right? So there is a glenoid cavity, and then there is this humerus bone. So that is glenohumeral. So when we move our hand like this, right? So this is our glenohumeral joint which is in action. This is a very shallow cavity. When you'll be learning lower limb, you'll find the acetabular cavity is big, right? The bone is actually, the head is actually inside, only the neck is coming out, and then it moves. Because in lower limb, we want stability, and in upper limb, we want mobility. Right? So that's why it is the shallow area on which the head is rolling, so that you get the better movement, bigger movement. In the lower limb, the head is like this, and only certain angular movements they are possible. So that's why the stability is much more. So when you get the mobility, the chances of shoulder dislocation are high. Yes, because it is a shallow cavity and then head slips out of it. It is what is called as the shoulder dislocation. We'll see that. Okay. So this pectoral is major, right? When the lower fibers, they contract. So what should they be doing? Right? Very true. So when only the lower fibers, say this is normal, only lower fibers contract, so it will take the shoulder down, right? It will take the shoulder down. Then it is those above muscles, they will contract and they'll take the shoulder back. When only the clavicular fibers contract, right? because it is attached to the humerus, so it will take the shoulder up, right? It will take the arm up. So that is what is called a shoulder flexion, right? It will take the arm up. When only the lower fiber is contracting, so that is what is leading to shoulder depression, right? It is leading to shoulder depression. Remember, for shoulder depression, only the lower fibers, they are working, right? From the angle perspective, just 10 degree, right? Because we can't depress much. At the most, how much you'll do, right? Just 10 degree, because then there is no space. So it will work only in that much area. And the muscle which is over here, that's right, that's our kite-like muscle, and that is trapezius. Trapezius. See, being medico, when you start doing exercise, remember no one can do exercise better than you, because you know what is trapezius, right? Trapezius is what gives your shoulder a cut, right? So actually, when your body is formed, it's like this. The V shape is by those latissimus dorsi, and your chest is formed by pectoralis major. These three muscles, right? If you do systematic exercise, how will you train these muscles? Obviously, if you do these movements in which that muscle is deployed, automatically those muscles will become more and more powerful, right? So you take a proper weight, right? And then if you are just going for shoulder flexion, yes, you are taking care of those clavicular part of the head. When you are depressing the shoulder, right? So you take those kettlebells or dumbbells and then you do specific movement, only the shoulder depression. It means you are focusing on those sternal muscles. Now, it's not so. Very important. Listen carefully. It's not so that these exercises are only for males. Normally, it is said that, okay, these are for males. No, for females, it is extremely important. Reason? That the entire figure of the female body is relying on these muscles only, right? It is relying on these muscles only. So if these muscles are weak, it will lead to destruction of that entire figure. So suddenly, that's the reason, suddenly it happens like that those who were, say, Miss College in their 20s, suddenly when you see them after 20 years, you'll find, oh my God, what have they done to themselves? Right? You must have experienced so many of them. When you look at their old photographs, you find that what is this? Right? Why can't you be equally effective from every aspect, even at any stage of the life? Right? So that's why these exercises, these are not only for males, it is for everyone, right? Okay, so here it is, the pectoralis major, right, contracting, and that's the pectoralis major. See how it looks like. See, this is a very good specimen, and over here you can see this one, right? This is pectoralis major, right? This one is latissimus dorsi, so that's our lats, and in between is what we are watching is axilla, and all these are serratus anterior, right? Awesome. And this entire portion is axilla or the armpit. Okay, the next one is when the shoulder is like this, right? The whole muscle would contract and it takes it near, right? So anything, it goes away, it is called as abduction, and when this muscle contracts, it takes it near. This is what is called as the shoulder adduction. So when entire muscle is contracting, it will take the arm near to the body. Entire muscle is contracting near to the body. Only upper one, so it takes up. When only the lower fibers, it leads to that depression, right? So how nicely they work. Meantime, let's see this muscle, right? See now, because it is seen so good, and here is our coracoid process, right? That's our coracoid process. On that coracoid process, and it is going towards the arm, so this muscle can none but it is coracobrachialis. Correct. It is coracobrachialis. And then we have got one more muscle which is over here. See nicely, it is just forming that posterior wall. So that's latissimus dorsi. And in between, right? In between there is one major. So that was pectoralis major, and this is, it has to be teres major. And how these muscles, they will be attached, they'll be attached on the humerus. On the lateral lip there is pectoralis major. On the medial lip, right, this is lateral, on the medial lip it is teres major, and in between it is the latissimus dorsi, or the lats. That's right. Here it is, this one, you know it, right? You know it. I need not even write. Pectoralis minor. All right, good. Individual pectoralis minor. Pectoralis minor has got one important function. Think it this way, that this pectoralis minor is getting connected over here. When it contracts, right, that scapula, which is, yes, with that scapula, which is like this, right, it is on the back side, it is on the back side. And this muscle is connected in front, right? So can you imagine that it is connected to the scapula? When it contracts, it will be drawing the scapula towards the chest, है ना? Right? This scapula, which is on the back side, it is connected over here with the pectoralis minor. When it contracts, so it will keep the scapula near the thorax, right? So we'll call it, it draws scapula forward. And then these are the muscles. This one is what? These all are the muscles. They are serratus anterior, right? So serratus anterior. It means one very nice thing. Serratus anterior and the pectoralis minor, they will keep the scapula near to the body. Now, in case if anything happens, let's say there is paralysis of serratus anterior and pectoralis minor, they are not functioning. So now there is no one to keep the scapula near to the body. And then that scapula, the moment someone would try to push, right, that scapula would go away from the body. Because otherwise, when you are punching, right, when you punch, so during that punch, to actually tackle the entire pressure system, when the muscles are moved, it is the scapula which is literally stuck to your thoracic wall. Now, when you are pushing or you are punching, these muscles, they are not okay. So in that case, your patient will be having winging scapula. That scapula will stay away, right? I'll show you a figure that how it really looks like. That is what is called as the winging scapula. It looks like as if he has got wings on the back side, right? Okay. Next is easiest things now start. Latissimus dorsi, you know this part. This one is coracobrachialis, right? And this one, this taking turn and attached on the lateral lip. So this is pectoralis major, right? Yes, you can, sure. And this one too is easy. Now you know this, right? This is just underneath the clavicle, right? And we'll call it subclavius, right? We'll call it subclavius, this muscle. Okay. Now you know this part also, right? This is easy. That's serratus anterior. Serratus anterior having 8 slips. But what I'm now interested is in this artery. This artery, which we named as, that over here we named it as what name? What name was given? Name was given was axillary artery. As it is going into axilla, we said that it is the axillary artery. When suddenly we are changing the name, right? The brachial artery, right? Brachial artery, right? It's not so we'll say that फिर से नाम बदल दिया. We have not changed the name, but it is the continuation of axillary artery, which will be now called as the brachial artery. When we'll be learning about it, we'll see that how the branches, what really happens, right? Okay, so now it is in arm. It is in arm, so we called it brachial artery. Anything is happening in this arm, they all are brachial, right? So that's how it goes. Let's move further. This is our serratus anterior from a very fine angle, very fine angle. This is like we are watching from the top, as if we have deployed a drone, and then this is like a bird's view, and we are watching it from that angle, right? Where, see, that's the clavicle as we are watching from the top. That's the scapula, right? That's the scapula. And here is what we are watching in the form. That, see, some of the fibers, they are emerging, right? That is, as serratus anterior has got 8 slips, right? 8 slips, 8, all those. The best answer, it is digits. It has got 8 digits, right? Like 8 fingers. This is root of spine. So that was the spine. This is root of spine. Root, just the point, root of the spine, the end of the spine. So from root of the spine, we have got digit number 1. So we'll just say as 1 of serratus anterior. Remember, there are 8 slips or 8 strips or 8 digits. The next one, here is all the way. This is 1, that's 2, this is 3, this is 4, this is 5, this is 6, this is 7, and that one is 8, right? This first one, it is from the root of the spine, from where it emerges. Then 2, 3, right? These are all emerging from, these are emerging from the medial border. Obviously, it will be the medial border, right? Medial border scapula. Medial border scapula. This digit 2 and 3, their importance is when you carry weight, right? So they are for weight carrying. So they are for weight carrying the weight. Because you'll be carrying the weight with your hand, and then that hand would be transmitting the pressure finally to this clavicle. But this clavicle is also associated, attached with the scapula, and that's how the pressure is actually getting distributed. Then it will be going to, say, these ribs to the central axis, and then from central axis it will be distributed across both the legs, and then it will go all the way down, putting the maximum pressure on the knee joint being the most complex joint. Root of spine? Yes, sure. Right, let me see if there is one more figure. I'll just show you. Just a minute. Right, I'll show you what is root of spine. Just a minute. Here it is. See? Again in this spine. Okay, I'll draw it. I'll draw it. Because else we have to go quite back. See, this is scapula. This one is acromion process. From acromion process, when you trace it back all the way, you trace it back, and the point where it ends, that is root of spine, right? This was the anterior portion, acromioclavicular joint, and then this is the top portion because we are watching from the top, right? And then in fact, you can feel it also from the top, and then you start tracing back, you will be able to reach to that point. And sometimes, right, this is the point which gives so much of pain, right? So much of pain when you have worked very hard or when you have lifted weight, because this say digit 1, 2, 3, they are weight carrying. So when you have lifted heavy weights, so it gives pain over here. Got it? So this is medial border, and then as we go below, right, for rest of the area, it is connected all the way to the lower region, the large triangular region. So as such, it is just a division, but all the way it is connected onto the scapula. So from scapula, these 8 digits, they go onto the ribs, right? So digit 4 and 8, these are important because they keep scapula near the body, near the body. So that's how these 4, 5, 6, 7, 8, the lower 5, that's the importance of it, that they keep it near the body, and the digits 1, 2, and 3, they are for the carrying of the weight. Now here is one case. Look at it. This is a case where that's the shoulder, this is the scapula, and we can see that clearly that this scapula, this clavicle, right, this clavicle is broken, right? That's the clavicle. This is the fracture of clavicle, because skin is not broken, right? So it is not an open fracture, it is closed fracture. But over here, it is the fracture of clavicle, right? Or you can say fracture of shaft of clavicle. Shaft means the entire body, right? Shaft or body of clavicle. This is much better. Can you identify? Right? See, here is the clavicle, right? That's the clavicle. See how badly the bone is broken, right? Can you see? It is broken. If you look very carefully, there are multiple pieces, right? Multiple pieces. So whenever you write fracture, so you'll be writing like this, right? You'll be writing like this. This means fracture, right? Not the hashtag, but it is the fracture. This is the symbol. And in fracture, there can be 2 types. It is either open fracture or it is the closed fracture. When we say open fracture, it means that skin is broken. So that fractured segment has literally broken the skin and it came out, right? So that is called as the open fracture. Closed fracture is what you really saw, right? Though there is fracture, but skin is intact. So that's why this is called as the closed fracture. So skin is intact, right? Then also there are, like, if there is just, this is the bone, right? This is the bone, and the bone is broken. So this is what is called as the simple fracture. When it is like this situation in which there are multiple pieces, so we'll call this thing as comminuted, right? Comminuted fracture. Do remember these names, right? Because parallelly you are learning new names, otherwise it will definitely be coming into orthopedics, but it's a simple name, right? But it gives a meaning that it means there are multiple pieces. Multiple pieces. What is the importance of it? In closed fracture, internal bleeding occurs. Well, whether the bleeding would occur or not, that depends upon whether the artery is damaged or not. So when we'll be discussing the radial artery, right? Or when we'll be discussing, say humerus, right? Let's make it simple. When we'll be discussing humerus, so at times it happens that because the artery is going very nearby, when the fracture occurs, that artery is also snapped off. So yes, in that case, there would be internal bleeding. But say close or open, it has got nothing to do with bleeding. What it tells is open means that skin is broken. When the skin is broken, why it is a dangerous thing? Because see, bones are extremely susceptible to catch the infection. And if the infection goes into the bones, if infection goes into the spine, if infection goes into the reproductive organs, and infection, if it goes into the brain, it is difficult to tackle, right? Because then the prognosis keeps on decreasing. So over here, when the fracture is open, that means skin is broken, you need to take care of it that infection doesn't enter into it. Otherwise, if the skin is intact, fine. Even if it is a comminuted fracture, even in this case, right, when there are multiple pieces, you have to operate. Comminuted means you have to operate, because such multiple pieces, they won't be automatically adjusting itself, right? You have to open, actually perform the surgery and put the pieces together, whatever the situation is. So that is where the surgery is needed. If it is like a simple fracture, right, say it is like this, so in that you try to put the broken bones together and then leave rest of the things to nature, and the whole bone would be, say, fused together, right? That those broken pieces will be fused together. So that is what is called as the process of reduction. Process of reduction. When you put it back into its original state, you don't have to operate, but that is possible in simple. Whenever there are comminuted multiple pieces, no way, you have to open it. And open or close, it matters a lot, because infection, right? Infection can penetrate very easily, because by the time the patient is reaching you, if it is an open fracture, then people must have tried so many things, right, in order to say, because they are scaring. It's scaring when the bone is shown through and through into the out of the skin, right? So someone must have pressed that rumal, or someone must have done anything, but yes, infection, chances of infection going inside becomes very high. Here it is. One more, right? This is what? This is the clavicle. This is acromion process. So this is acromioclavicular separation, right? Normally they both are together, but yes, the moment it is separated, broken, so they are misaligned. See, the alignment has been lost. One more. Yeah, here it is, right? Before even I say something, you will be able to identify. This is winging of scapula. Winging of scapula. Why there is winging? Because we said that in serratus anterior muscle, it is the serratus anterior muscle in which there were 8 digits. Out of those 8 digits, 1, 2, 3, and 4, 5, 6, 7, 8, right? Everyone was having specific meaning. This was at the root of the spine. They are meant for that, carrying the weight. And this 4 and 8, their function is, sorry. Yeah. 4 and 8, their function is to keep the scapula near the body, right? So here, these are the fibers which are affected. These are the fibers. These are the fibers which are keeping the scapula near. Now in this, you can see a very clear margin. The entire scapula as if it is coming out of the body. That is as if this is a wing. And the nerve which is damaged in this case it is called as the long thoracic nerve, right? It is a long thoracic nerve. Why this nerve? Obviously, the nerve which will be traveling so much, it is easy to be destroyed. It is easy to be affected. Small nerves, so it is like within that short span, you have to attack them. This is a long nerve, right? So this is a long nerve, so it is very much susceptible to this injury. When it occurs, very common in case of knife attack, right? Knife. So it can easily be damaged. Knife attacks. The nerve is cut. Or when patient is having any sort of, say, carcinoma, and you are going for RT, radiotherapy. And in that radiotherapy, it is what is called as the post local intensive radiotherapy. This area, right, where the radiotherapy is given for, say, carcinoma of breast or anything. So in such case, this long thoracic nerve is affected. When this nerve is affected, it will lead to winging of scapula. So it means now we know that it is the long thoracic nerve which is supplying serratus anterior, right? It's like other way around, right? This should be the arrow. So it is the long thoracic nerve. See how long? So it is traveling so much, and it is supplying serratus anterior. So when it is affected, it leads to winging. One more. And this is to find, this is where sternoclavicular joint that is affected, right? There is a sternoclavicular joint is dislocated. More we see. Yeah, here it is. This is what I was telling. Don't watch at this patient's image first. Watch the X-ray. Try to identify, right? Because you have seen the bones, you will be able to pick up so many bones even on the X-ray. I'm just drawing the outlines. See here, as I draw this, so it is clavicle. All right, good. This is clavicle. Now, can you identify the humerus, right? Yes, we can, right? Change the color. This is the head, right? Then I'll erase these lines, but right now just try to see this. And it goes like this, and that's the humerus. Okay, so I'll just write H. Now, if you see carefully, I'm just zooming it. Can you appreciate the scapula? Can you appreciate the scapula? Can you see the scapula? Where is it? Right? Try to figure out. Now I'll draw the outlines of the scapula. See, here it is. Here it is going like this, and it is like this, and it is like this, and then there is that, and right, it's making sense, right? Can you see the scapula? So this is scapula, right? That is scapula. Now watch this part. As we said, that head of the femur, head of the humerus, right? Head of the humerus will be forming a shallow cavity with the scapula, which is called as the glenoid cavity. True? So here, if I am supposed to write that where is the glenoid cavity, so that is the glenoid, right? That is the glenoid. This glenoid is a small shallow area. On that head is attached. So obviously glenoid and the head, they should be together, right? No, come to that, right? The head should be together. So that's why this head can really move. That head can really move on this glenoidal system. But what if in this case it goes like this? That glenoid is over here and the head is here, the entire bone, right? This is think like this is humerus. Now it is here. See the situation. It is nothing but it is very fine shoulder dislocation, right? It is shoulder dislocation. That's so common. That's so common because glenoid is shallow. There is a big head and then it slips out. So then that leads to immediately the round contour of the shoulder is lost. See, that round contour is lost, right? And then there are various shoulder dislocations, out of which the most common is the anterior dislocation. Anterior dislocation. dislocation of shoulder. Anterior dislocation is the most common, right? Now, how will you reduce it? So nothing has been damaged. It is over there, but that shoulder has been dislocated from that glenoidal cavity. This is what is called as the Kocher's method. This is what is called as the Kocher's method. Now this method is very old, maybe over 3000 years old, right? Even in the pyramids, even in those Egyptian pyramids, right, there are few drawings, and those drawings, they are quite similar to as if someone is reducing this shoulder dislocation. Shoulder dislocation, you'll find that even in Africa, when you go to those tribes, right? In those tribes, there is like one is considered as male, and anyone would give a girl to that boy only if he kills one lion single-handedly with his spear, right? So now imagine with what force they must be throwing it. Now whenever such things are done, it is possible that shoulder might get dislocated, right? Then those boxers, right, when they are punching very hard during the practice, shoulder dislocation occurs. How to reduce it? Because this shoulder dislocation is extremely painful. Why I am teaching you how to reduce it? Because yes, you can reduce it, and it is not requiring a very huge science, just the proper step, right? Just the proper step, and within minutes you will be able to say put that thing back to normal. So that is what is called as the Kocher's method, and we'll see how to do that, right? Actually, you will be doing it on yourself. That's what is called as the Kocher's method, and it is the best method, best way to remember it. So instead of talking about, yes, there would be this 90-degree flexion, this, that, everything, no, we'll do it. Once we'll understand, we'll write it, and you'll never forget it. So first thing first, what you will do is, right, all of you start doing it. Remember, shoulder is dislocated. So instead of this round contour is lost, right, and here is the shoulder. So first thing, 90-degree. I'll keep on drawing some simple figures. 90-degree. So this is the arm. I'm sorry, this is the forearm. This is the forearm. That's the arm, and make a 90-degree. And that's the hand, right? You are holding the hand of the patient. So right now you'll do it by yourself on your hand. So here it is, 90 degrees between your arm and forearm, right? 90 degrees. Okay. Next important point in this, the arm should be near to your body, right? It should not be like this. It should be near to the body. So how will we write it technically? That arm should be adducted. So there is adduction. So here it is, this is abduction, this is adduction. So now I am into correct position. Okay. Second step. Your elbow, right? It is like you'll be holding the elbow, right? And then take it out, right? Take it out. So elbow, holding the elbow and take it away from body. Take it away from the body. In which plane? In sagittal plane. In sagittal plane. In sagittal plane. Sagittal plane means coronal plane was what? Crown, right? From crown. This headphone is like a crown. So this is coronal plane. Sagittal plane is what? It is like this, which will divide my body into left side and right side. So if I'm holding my hand like this, right? Actually it is, but just to show, hand like this. So when I say I'll be moving my this elbow into sagittal plane, it means I am doing it like this, right? It is away from the body. Got it? And then the third step. The third step is when doing this, and then internally rotate. Internal rotation, internal rotation, and done, and done, right? It is this step which should be performed slowly. And at times, if the patient is not unconscious, so then ask him about his name, how it happened, what were you doing, this, that, and it is at that point just lift it and then internal rotation, right? So I'll just repeat. 90 degrees, arm is adducted, so near to the body, right? And then lift the elbow, and then you will do slowly, right? And then internal rotation. As soon as you do internal rotation, head slips back into the glenoidal labrum, glenoidal cavity, and this is what is called as the Kocher's method, right? That is what is needed for reduction of the dislocated shoulder joint. So this was what was there, right? And that's what we were planning to discuss today. So this is pectoral region, right? That was the pectoral region which we talked about. So tomorrow we'll be discussing the brachial plexus, with reference to our today's topic. Yeah, about notes. Yes. It's good. Say in notes, what you do is, yes. Yeah. So for anatomy, every structure, right? It can be drawn like this. So this is what, this you can say this is like humerus, right? We are not talking about this lower end because we are not discussed, but this much you have discussed. So similarly, say this, that would be always your clavicle. You can even do it like this. That is also always your clavicle. Keep drawing and say that's the sternum. So keep drawing all those muscles. So instead of remembering it, remember it like this, that this is the clavicular head, this is the sternal head, and then it is going over here. So do draw it like this. Now this is scientifically a correct figure, which will convey the meaning. So when you draw such things, these are your notes. These are your notes. And when you see that, you'll be able to remember it very easily. Now, once you have revised this today's topic, then you start asking question. That's what I'm telling. Say how we can draw muscle and processes. Muscle is just like this. You will just draw. It's okay, even if it is not very much artistically correct. But this much you should know, that when you draw a muscle like this, that right, this is the clavicular part, and this one is from the sternum, and this one over here, it is the lateral lip. And in lateral lip, right, remember that two majors, and here is the lady, right? This was pectoralis major, this was teres major, and this is the latissimus dorsi. That way, you just draw such figures. The real figures or the dissection figures, they are just for your understanding, to look like how it really looks like. Unless and until you don't draw such crazy figures, it is okay not to be artistically correct, but it is very much needed that you should be scientifically correct. And by scientifically means that, okay, we know this is the clavicle, this is for the sternum, right? So when you draw it like this, it will create a tremendous impact. You'll be able to remember it so easily. And tomorrow, say for example, in brachial plexus, so actually we'll be drawing the entire brachial plexus. Again, in the form of a very specific step-by-step method. Same way, today also, in today's session, you revise the whole thing. But during revision, what you can do is when you play back this same video, increase the speed. Increase the speed to 1.5 times, 1.5x, or you can make it even 2x, and rapidly start drawing all these. We discussed everything in depth, but then when you put it on 2x or 2.5x, yes, things will go pretty fast, but at the same time, your brain will also start working that fast, right? I'm today or tomorrow, I'll be making that group, right? So that in that case, that Instagram, so that we can even be in touch. And some of the, say I'm compiling all those notes, so they can also be given to you. Tomorrow, we meet at the same time with the brachial plexus, right? Thank you so much. That's a topic for tomorrow. Thank you so much and see you soon. Take care. Bye bye.